afternoon. At the outset, I congratulate Jyotidev for organizing such a wonderful CME here. Regarding the topic is addressing challenges in the management of diabetes in the young. Following the ICMR INDIAB study, data reveals that about 70% of patients in India with diabetes belongs to the age of 40. So when we were students, diabetes in the young meant it is type 1. Now there is a big shift from type 1, type 2, MODY, LADA and so on. So this topic is a practically very important topic. Even most of the doctors are biased regarding the diagnosis of type 1 diabetes in the young. To deal with this topic, we are having the excellent speaker, Dr.Sreejith. He doesn't need any introduction to this crowd. He is the IMA state president. He is a best speaker and he is a best research award holder by RSSDA, and he's presented so many talks in different forums, and his special interest is in diabetic education. Over to you, Sreejith.
Thank you very much. At the outset, let me congratulate Dr. Jyotidev, who has brought the capital of Trivandrum and the capital of Kerala into the global academic scenario of diabetes. It's a wonderful conference which he has organized, and congratulations, Jyoti. We are so very proud, not just because he comes from Trivandrum, but also both Dr. Jyotidev as well as Jayakumari are my classmates, and the batch of 1984 MBBS is very, very proud. And I'm also aware that this program is going live through live streaming, and a lot of our classmates from 84 are watching this program live from all over the world. So a big hi to all of you sitting out there. I don't know which camera to look into. A big hi to all our classmates, and we are really very proud of you, Jyoti. You have done all of us very proud, and thank you for bringing this excellent program to Trivandrum. And thanks, Jaya, for all that very nice words. She is again one of our favorite classmates. Currently, she is a professor at Medical College. Now, shifting gears from Matthew's excellent lecture on what is in future, let's all come to ground zero, on to ground earth, into our clinics, on what we are going to do every day. We all know that every day we are getting more and more young people with diabetes. Let it be children, let it be adolescents, let it be young adults. And often we are in a dilemma as to what to do, what type of diabetes it could be, and how to manage that. So my attempt in the next 20 minutes or so is going to be exclusively on a clinician's perspective. I'll not be going into more of the epidemiological and other data, but a clinician's perspective on how exactly should we go about managing diabetes in the young. We are all aware about the definition of diabetes. I'm sure in the initial sessions that has been dealt with. And diabetes in young is no different. It's a fasting sugar of more than 126, and after glucose load of more than 200 and an A1C of more than 6.5, the definitions remain the same. Now, when we get a young patient with diabetes, it could be either type 1 diabetes or type 2 diabetes, or it could be some other form of diabetes. It's as simple as that. We are all aware of this classification of diabetes, whereby we know that there is type 1, there is type 2, and other diabetes. And amongst these other forms of diabetes, there are so many headings. And there are a lot of other diseases which either produce diabetes or are associated with diabetes. And amongst them, as far as children are concerned, or young adults are concerned, as far as the youth is concerned, the ones which have been highlighted, that the monogenic forms of diabetes, the mitochondrial diabetes, genetic disorders leading on to diabetes are important. And also there could be some drugs like the steroids, the thyroid hormones, beta agonists, thiazides and dilantin, etc., which could again be diabetogenic. Again, there is another group which are some of the syndromes which are usually associated with diabetes, And then you have a whole lot of endocrine diseases which are again associated with diabetes. So this is a general outline of, other than type 1 and type 2, what all can be expected. Now let's try to narrow it down a little further. Now when you see a patient with diabetes, let's say a patient less than 20 years of diabetes, what are the chances of type 1 and what are the chances of type 2? Almost 80% it would still be type 1 diabetes. Though in various populations, especially in our country, in Asian population, in Indian population, type 2 diabetes is increasing. Nevertheless, more than 80% of diabetes still would be type 1. If you further classify into age less than 10 years, then almost all diabetes of age less than 10 years would be type 1. Type 2 would be rare, other forms are even rare. But when you go to age more than 10 years, as you near 20, then the chances for type 2 diabetes increase, and you can see that in certain population like the Asians, the American Indian youths, in fact type 2 diabetes when you go near the age of 20 could be as much as 80%, type 1 being around 20%. So that means when you have a young patient with diabetes, age less than 10, the chances for type 1 are high. There could be a little chance of type 2 and a very little chance of other forms of diabetes. But when the age is more than 10, when it nears 20, the chance for type 2 goes up. And when it is more than 20, the chance for type 2 is really high compared to type 1 diabetes. So let's say around 80 or 78% or around 60 to 70% would be type 1. Around 20 to 30% would be type 2, and around 2 to 3% could be other forms of diabetes when you consider diabetes in the youth. Currently, there are around more than 500,000 children globally having type 1, and our region, it's spread globally, including in our country and in Asia. Now, what is the risk of an identical twin to have a type 1 diabetes? It's around 36%. For a sibling, it is around 4% by 20 years and around 10% by 60 years. And the risk of having an offspring with type 1 diabetes for a type 1 diabetic patient is much higher in a diabetic male, which is around 3 to 8%, compared to a diabetic female, which is around 1 to 3%. Now, these are the classical symptoms of diabetes: polyuria, polydipsia, weight loss, and also there could be blurring of vision. And usually when you check urine, there could be either glucose or ketones or both in urine. So that's a classical presentation of type 1 diabetes or diabetes in young. There are two practical tips to remember. One, you should not rush into a diagnosis based on one single glucose value. And secondly, if the glucose value is really high, then don't subject the patient to an oral glucose tolerance, because when you give additional glucose, there's a real chance for precipitating ketosis. Now, apart from this classical presentation of type 1 or diabetes in young, there could be certain subtle presentations or variant presentations of diabetes in young. It could be either in a non-emergency situation or it could be as an emergency situation. Now, non-emergency, you can have a baby or a child who was, very well behaved, but right now there is enuresis, the baby keeps bedwetting or the child keeps passing urine here and there. It would be good to check the blood sugar. Could be vaginal candidiasis, especially in prepubertal girls, chronic weight loss or failure to thrive, as the pediatricians would like to call, irritability, decreasing scholastic performance, recurrent skin infections. So all these should prompt the clinician to check for diabetes. There could be some emergency situations presenting in diabetes, like severe dehydration, frequent vomiting, continuing polyuria despite the presence of dehydration, weight loss due to either loss of fluid, muscle or fat, vomiting and abdominal pain, and acetone detected on breath. So all these we know are dangerous indicators of diabetes ketosis. So the patient could have a non-emergency presentation or an emergency presentation. In ketosis, again, there could be hyperventilation. There could be disordered sensorium. We are all aware that many a times kids are brought to the casualty in a disordered state, and we check their blood glucose and find that it's often high. That's usually how type 1 is diagnosed. Decreased peripheral circulation and rapid pulse, and the patient may even present with hypotension and shock when there is severe dehydration. So all these could be emergency presentations, especially in type 1 diabetes. Now, what are the diagnostic difficulties? Now, when there is a hyperventilation, if you don't suspect, then we may think that it is either pneumonia or asthma. But look at the chest, cough, breathlessness, etc. If they are there, they are more in favor of a respiratory disease. Abdominal pain is often mistaken as acute abdomen, and the patients generally get referred to the surgical specialty. There are cases, there are places where the abdomen was even opened, and thereafter you realize that it's just a severe abdominal pain precipitated by ketoacidosis. Polyuria enuresis can be misdiagnosed as UTI. Polydipsia can be attributed as psychogenic, and vomiting may be misdiagnosed as gastroenteritis. Now, the rule of thumb is, if you have a child or a young adult with hyperglycemia, and if you are in a doubt which drug to give insulin. Treat them with insulin, and once they are stabilized, go in and typify which type of diabetes it is, and thereafter we can give the drug of choice that for that particular condition. Now, differentiation between type 1, type 2, and monogenic forms of diabetes is important, because the management would differ. We have to consider that the diabetes which we are dealing with could be atypical if the patient has one of these features. If there is an autosomal dominant type of inheritance, if there is associated deafness, optic atrophy, or other features which can suggest a syndrome, if there is either marked insulin resistance, or if the insulin resistance is too low, that the patient is requiring only very little doses of insulin, or if there is a history of drug intake, the drugs which I alluded to a little earlier, if some of these are there, then we should suspect that probably it's not type 1, it's something else. Now, this is a very useful slide. Here we have 3 categories: type 1, type 2, and monogenic. Now, as I already told, less than 10 years, the probability of type 1 is very, very high. More than 10, close to 20, let's say around 50-50 chance of type 1 and type 2. And the other forms of diabetes are actually very rare. Even when you take it less than 20, it will be only around 1 to 2%, but still, it is a possibility. Now, how do we clinically make out which form of diabetes it could be? One, genetic, of course, we cannot look into that, but if you have a facility to assess the genes, then monogenic forms of diabetes have a defect only in one gene, whereas in type 1 and type 2, it is a polygenic disorder. Age of onset, type 1 will be very young, 6 months to young adults, and typically around puberty. And type 2, usually pubertal or even later. Monogenic forms often post-pubertal, except 2 varieties, glucokinase and neonatal diabetes, which present very young. Autoimmunity, this is something which is unique, because the antibodies you will find in type 1 diabetes, and very rarely, probably not, in type 2 and monogenic diabetes. So if autoantibodies are present, the chance of type 1 is definitely much higher. Ketosis is definitely associated with type 1 diabetes, very, very uncommon in type 2, can very rarely occur in monogenic diabetes. Glycemia would be very high in type 1, could be variable in type 2, and again variable in monogenic, but very high blood glucose is usually an indicator of type 1 diabetes. Obesity, we all know, is generally associated with type 2 diabetes. So if the patient is obese, it's probably type 2. And when associated with acanthosis nigricans, it's almost certainly type 2. Acanthosis nigricans is a telltale sign of type 2. And frequency, I already told about that, 90%, 10%, and 1 to 2%. Parent with diabetes is very unusual in type 1 diabetes. We already saw that the chance for inheritance of the offspring is very less. Whereas with type 2, there would be a family history, and in monogenic forms, almost certainly there would be a family history of diabetes. So this is how broadly, even clinically, we can make out between type 1, type 2, and other forms of diabetes. Whenever in doubt, these two tests will be of immense help, C-peptide and autoantibodies. We all know that C-peptide will be very low or not detectable in type 1, but may not be in the initial stages. But if someone has detectable C-peptide, reasonable levels of C-peptide, with mild hyperglycemia, after 2 to 3 years of onset of diabetes, it's not likely to be type 1, because C-peptide would have waned off by then in type 1 diabetes. So generally when you do C-peptide and autoantibodies, if the autoantibody titers are high and if the C-peptide is either undetectable or very, very low, the chance for type 1 is much more, whereas the reverse would be true for type 2 diabetes. However, there could be still dilemmas, because there could be frank type 2 diabetes with acanthosis, where insulin antibodies could still be present, and the other way around also, overweight children, since the overweight children continue to increase. But these are very rare, and it's generally not the rule. Now we'll spend maybe around 2 minutes each or 3 minutes each on type 1, type 2, and monogenic forms in specific, and then we'll wind up. Type 1 diabetes, we know there's a T-cell mediated pancreatic islet beta cell destruction. The peak age of diagnosis is 12 years, and one of these serological markers, or more than one, could be positive. And the serological markers or the autoantibodies include the islet cell antibodies, the insulin autoantibodies, the glutamic acid decarboxylase, insulinoma-associated 2 molecule, and the zinc transporter 8 or the insulin T8 antibodies. So these could be present. Again, we are all aware of the honeymoon phase in type 1 diabetes, where the insulin requirement could go very low. The patient could be maintained on very little doses of insulin, but we all know that in a matter of few months, this phase wanes off and frank type 1 becomes manifest. Management calls for multidisciplinary team, and Jyoti has arranged lectures in all disciplines. There are dietitians speaking, there are psychologists speaking, there are exercise trainers speaking, clinicians speaking. All of them have to be combined into a team to manage type 1. It is not as simple as writing down a prescription, and education of the child and family is important, and diabetes self-management education, medical nutrition therapy, psychological support, all these becomes very important in managing type 1 diabetes. The drug of choice for type 1 undoubtedly is insulin. It can be given as a multiple daily injection or as an insulin pump, a continuous subcutaneous insulin infusion, whatever the patient can afford, but the patient would require basal insulin as well as bolus insulin. And match prandial insulin according to the carbohydrate intake, the pre-meal blood glucose, and anticipated activity. Insulin analogs are better because it will reduce the risk of hypoglycemia. I'm sure some lecture about insulin would have already been there. And consider screening for other autoimmune diseases like thyroid, vitamin B12 deficiency, celiac disease, etc., if appropriate. Now we come to type 2. And as I told earlier, the chances for type 2 diabetes or the incidence of type 2 diabetes is steadily going up in young patients. We all have patients less than 20 years in their teens having type 2. And unfortunately, the numbers are going up. They are not reducing weight. They are not dieting. They are not doing exercise. And the risk is actually very severe. And unless we put our kids in hostel, they also stand a risk of obesity. I have admitted my son recently to a hostel, and one good thing which has happened is he has reduced almost 5 to 10 kilos of his weight. His obesity has come down. But otherwise, with the rich food which we all eat, the chance for type 2 diabetes, especially in children, is going high and high. Now, which are the children who should be screened for type 2 diabetes? ADA says that if the weight is high, more than 85th centile or more than 120 percentage for ideal height, or with any of these risk factors, that is a family history of type 2 diabetes or high risk category like which we have a high risk ethnicity, signs of insulin resistance like acanthosis, or some of the diseases which are associated with insulin resistance like hypertension, dyslipidemia, polycystic ovary, and a maternal history of diabetes or GDM, then all these are indications that the child should be screened starting from the age of 10 at least once in 3 years to detect type 2 diabetes early. Now, if the kid is severely symptomatic, maybe you would consider insulin, or if they're young adult, but otherwise the drug of choice is metformin. And there is no doubt about that. Don't worry about the age. Start with metformin in a small dose, gradually keep titrating upwards until you reach the ideal dose of around 1 gram twice daily, or whatever dose the young adult or the kid can tolerate. And then we have this conventional chart. If metformin fails, we go to the next OHA. If it fails, we go to either insulin or the next OHA. It all remains. And this is another useful chart which says that if the patient is severely symptomatic and with high levels of blood glucose, consider insulin. But if the child is not very symptomatic, and with low levels of glucose, start with metformin. If it fails, add the next drug, especially sulfonylurea or insulin if you feel that it's more appropriate, and gradually titrate to maintain a good glucose control. Now let's have a brief look over the next 2 minutes on some forms of monogenic diabetes. Especially, again, I stress that it's more of an academic exercise. Don't think that most of our patients are going to have MODI from tomorrow. Yes, you may encounter 1 or 2 patients, but it's actually less. Vast majority of our patients are still type 1 and type 2. But we need to be aware that there are certain types of diabetes which are produced due to defect in a single gene. That is why it is called monogenic. Single gene in different locale. For example, you have neonatal diabetes, which is usually diagnosed in the first 3 months of life. It could either be transient or permanent. A transient type, when there is an abnormality in chromosome 6q, the ZAC and the HYMAI genes, there is an abnormality. Usually the diabetes resolves within 12 weeks, but it may relapse. There could be a permanent neonatal diabetes, requires insulin lifelong, and again the mutation is in the genes which are mentioned here, which affect the potassium ATP channel. You have another diabetes called the HNF1 alpha, that's the hepatocyte nuclear factor 1. It's MODI, it's not MODI, it is MODY. It's that MODI in diabetes, MODI3. That is the commonest form. Young onset diabetes, it not being insulin dependent, not developing ketoacidosis in the absence of insulin. So you will have some patients maybe in their late teens or early 20s. They require either very little dose of insulin, but even without insulin there is no ketosis. They are fairly stable, fairly comfortable, are not very obese. There could be a strong family history. Suspect MODI3, which is the commonest form of maturity onset diabetes in young. And they are markedly sensitive to sulfonylurea. So here the drug of choice is neither insulin nor metformin. It's actually sulfonylurea. With small doses, they would respond very well. There would be a family history, typically diagnosed in their 20s, 30s, or 40s. OGTT in early stages. There is a large glucose increment with OGTT. Glycosuria at relatively low blood glucose because the renal threshold is low. So you get a patient in 20s or 30s, very little insulin requirement, strong family history of diabetes, not very obese, urine shows high sugar, blood glucose may not be very high. You do a OGTT, the sugar will jump up. Suspect MODI3 or HNF alpha gene mutation and try treating with sulfonylurea. This is again a rare form, MODI1. Everything is similar, but the renal threshold is not that low, and they are again often sensitive to sulfonylureas. Mild fasting hyperglycemia due to glucokinase mutation, that is MODI2, again very rare form. I'll not go into details of all these. This is something which we have all learned in our MBBS days, and also which is a favorite question for most entrance exams. The Wolfram syndrome or the DIT mode, diabetes insipidus, diabetes mellitus, optic atrophy, and deafness. It's fairly obvious the patient will be deaf, there will be visual disturbance, there will be frequent urination, and also there would be diabetes. The drug of choice is insulin. There could be still some rare varieties like the Rogers syndrome, thiamine responsive megaloblastic anemia, renal cyst and diabetes syndrome, mitochondrial diabetes. That is another interesting factor. Mitochondrial diabetes actually comes from the mother. It's maternal transmission, and it's transmitted actually through mutated or deleted mitochondrial genes. And it's maternally inherited. Sensorineural deafness and short stature may be there and may require insulin. Mitochondrial diabetes is again a favorite entrance question, that it's the only maternally transmitted form of diabetes. Now, when to consider other forms of diabetes? The diabetes presenting less than 6 months of age, consider neonatal. If the parent is definitely affected, the child is not very obese, consider familial diabetes. Mild fasting hyperglycemia, again. Good glycemic control on small dose of insulin and not developing ketoacidosis, consider other forms. And diabetes associated with extra pancreatic feature. Detectable C-peptide when glucose levels are high, even after 3 years of diabetes, unlikely to be type 1. And negative pancreatic autoantibodies, again, unlikely to be type 1. So these are the situations where you would consider other forms of diabetes. Genetic testing, yes, theoretically it is possible. Hope in the near future we'll have Jyoti bringing in genetic research facilities here also. But time being, probably we'll have to go into one of these websites and request to some research centers to do that, because it's not routinely done. I think in some of the hospitals in Trivandrum, it's coming up. Genetic testing is coming up. I think NIMS is bringing a project on genetic research, or on genetic testing, gene testing. Now, these are the targets which we are aiming at. It will not be as strict as in a usual patient. We'll be little relaxed. You can see here that we would like to keep the pre-meal between 100 to 180, post-meal around 110 to 200 in very young kids. In older kids, 90 to 180 pre-meal, 100 to 180 post-meal, and in young adults, 90 to 130 pre-meal and 90 to 150 post-meal. So these would be our targets, and the A1C is also mentioned here. Would like to keep around less than 8.5 in very young kids, less than 8 in school-going children, and less than 7.5 in young adults and adolescents. It's very difficult, though, to achieve these targets. You can see here that achieving these targets is actually a big challenge, especially in kids and young adults. I think another 1 minute, Jyoti? 2 minutes? 1 minute? Probably I've finished with the diabetes in young part. Now, whatever I'm going to say in the next 1 or 2 slides is generally applicable to all diabetics. I'll not elaborate into that. It's not only enough that you control the blood sugar with all these measures, like diet, exercise, insulin, monitoring, and so on. But it's also important that you look into the comorbid situations, just like you would manage adult patients. Look into hypertension, look into dyslipidemia, look for retinopathy, look for nephropathy, and manage all of them as well. Insulin, of course, there would be another session on insulin probably, and we have already mentioned that the patient would require both. Self-monitoring of blood glucose is very, very important. They have to check their blood sugar, and right now we also have the continuous glucose monitoring, and I am aware that there is going to be a separate lecture on continuous glucose monitoring, so I'll not go into the details. This is the famous ALSR which Jyoti Dev recently gave to one of our patients. It's extremely useful in type 1 diabetes and in diabetes in young as well. And based on that, you titrate the blood sugar. So these are the various checkup which we would do. Look for microalbuminuria, control blood pressure. If required, use ACE inhibitor, check and control dyslipidemia, and also look for retinopathy, and if it is there, try to control that. We have some excellent guidelines which are available. I could, in 15-20 minutes, just glance through some of these. But if those of you who are interested in reading more, IDF has brought out a good guideline, the ISPAT guideline. Also, we have this excellent article which has come up in Diabetes Care. NHS, again, has brought out a guideline. So maybe those of you who are interested can look into one of these. So the take-home message is, all diabetes in young is not type 1, nor is it type 2. There could be other forms as well. So let's keep our eyes open and try to see which type of diabetes it is, because the management would depend on that. And let's try to achieve the best possible A1C at the same time avoiding hypoglycemia, so monitoring becomes important. And apart from managing diabetes, it's also important that the comorbid conditions and possible complications are also addressed too, and thereby assuring a good future to our diabetic patients. This Cape of Good Hope, if Binu Luke is watching, it is very close to his place. He is our classmate in South Africa, and let's hope that we will all have a good time in managing diabetes, especially after this wonderful symposium which Dr. Jyotidev has so elegantly presented. Thank you very much for your attention.
Thank you, Sreejith, for the clear and crisp presentation. The topic is open for discussion. There's a shortage of time. 1 or 2 questions are entertained.
I made an arrangement with Titus sir that if he asks questions, he will not be in IMA. So sir has agreed to that. Titus sir usually spares me from questions.
Attended many programs, but have some questions.
Yeah, please.
In your, on a clinician's perspective, your classification of type 1, type 2 and others, the category of others, what is the importance for a clinician perspective to identify in treating a patient other than insulin or OHA in the category of others?
Yeah, very good question. So that is exactly what we are coming to. He has actually hit the nail right on its head. Because there could be some MODY diabetes where sulfonylurea is the drug of choice. So conventionally, we would like to treat type 1 with insulin and type 2 with metformin. But here, neither metformin, it's not that you cannot give insulin, you can. But then, if you are able to identify, then you can treat with sulfonylureas. And then again, it's actually the reverse. It's more important to identify type 1. We should not be confusing and missing out type 1 and trying with OHS. So it's more important to identify type 1. So the emphasis is that yes, it's good if you can identify one of those rare forms, but please keep it in mind that rare things happen rarely, and whenever in doubt, use insulin. In other forms of diabetes, they remain the same. They remain the same. The chance for, what sir asked was what about the chance for complications in various forms of diabetes? Now, any form of diabetes, poorly managed, ultimately they lead to nephropathy, retinopathy, and all those complications. But when you come to a young adult, you are trying to give the same targets as that for an adult. No, because there are 2 reasons. One, C-peptide is what is more accurately, which can be seen, and C-peptide levels are not affected by your exogenous treatment. Now, you give insulin to the patient, you give OHAs to the patient might have taken treatment from somewhere else. All this will affect the insulin levels. And insulin as such, I don't think it's a reliable assay which we have. So generally, a mark of insulin secretion is the C-peptide.